He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome, folks. It is Stay Off My Operating Table with Dr. Philip Ovadia. We are joined today by someone that I was thrilled to see back on the show. And in my mind, we've had her very recently. But I went back and checked. It's been almost 4 years.
Oh, wow.
Yeah.
Cynthia Thurlow. Phil, I just love listening to the two of you talk. I'm just going to shut up. And if you say something I'm confused about, I'll speak up. But otherwise, take it away, my friend.
Yeah, sounds good. I am very excited to have Cynthia back on as well. And I knew it was not quite recent, but hard to believe it's been quite that long. And really excited to have a new conversation with Cynthia, learn what she's been up to, talk about her upcoming book, which I'm very excited for. And just, I'm sure this is going to be another great conversation. Cynthia, maybe because it's been so long and people may not have gone quite back that far in our archives, just give the brief version of how you got where you are today. And I always love hearing your story because it is just such a great story, of course, around your TEDx talk and everything that went on.
Good to be back, Jack and Phil. I'm a traditional trained allopathic nurse practitioner, and I spent 20 years working in clinical medicine and I was predominantly focused on cardiology, but also did ER medicine. And 10 years ago, I got really tired of writing prescriptions for lifestyle related issues. I felt really strongly that a lot of what my patients were coming to clinic or I was seeing in the hospital were mediated by poor lifestyle choices, not enough sleep, not managing their stress, standard American diet, lack of physical activity, and we could go on and on. And so 10 years without a business plan, I took a massive leap of faith and left clinical medicine and almost instantly started attracting a tribe of women that were going through exactly what I was, the perimenopause to menopause transition, who felt misunderstood, unsupported by their licensed medical professionals. And so from there, I created one-on-one programs and group programs. And then in 2018, I decided to do a TED Talk, and I've done two, but my second one went viral, and that kind of catapulted me into being a thought leader in the metabolic health space, which is really what I've been doing for the past 25 years. And so I wrote a book on intermittent fasting for women in 2022. And really, since that time, I've just been fine-tuning my interests, which have always been around the gut microbiome, have always been around metabolic health. And so now I kind of humbly sit back and say that a lot of great things have come out of that decision to leave clinical medicine. I don't question it at all, as I'm sure you don't either. But for a lot of patients, understanding that the traditional model of care is great for urgencies and emergencies, but we really miss the boat on prevention and chronic disease management. And so now I get to practice the way I want to and speak on stages and help inspire other medical professionals to consider doing the same.
Amazing. Let's get into why you've come to believe that the gut is so important. The new book, by the way, is called Menopause Gut. Those are two things that might not have an obvious connection. And maybe before we get to that, let's just talk about why is the gut so important to our health?
Yeah, I think when you and I went through our training, we probably never learned about the gut microbiome. And yet we've had this burgeoning amount of research over the past 5, 10 years. And so when we're talking about the gut microbiome, let's define what it is, because I think everyone that listens to this podcast knows where the heart is, knows where our brain is, but the gut microbiome doesn't seem quite as tangible. And so we're really speaking to 40 trillion bacteria, viruses, fungi, and protozoa that are incorporated inside the large intestine or colon. And so there is an interface between the gut microbiome and every organ system. There's a gut ovarian axis, a gut brain axis, a gut bone axis, and on. And I would make the argument that most clinicians are not even thinking about the health of the microbiome in terms of immune function, bone health, hormone regulation. And I think it's really the missing link. I think for many individuals, they think this transition for women and for men too, although it's not nearly as dramatic. Andropause is a little softer of a landing. I think for a lot of patients, they think all they need to do is slap on an estrogen patch. And I'll be the first person to argue that if you're not looking at the microbiome, you're very likely missing an opportunity to support women's health, especially as they're navigating this decline in hormones and changes in neurotransmitters, which impact how we perceive the entire world. It is not just a hormone decline and then we don't sleep well. It is far more dramatic. It impacts every single cell in the body.
And these changes that occur during menopause, do you think they're unveiling gut problems that were there to start with? Or is it the other way around? Is it gut issues that maybe contribute to the changes in the hormones and the symptoms that go with that?
I think that's such a great question. I think it's a little bit of both. I think if someone has been eating the standard American diet, is physically sedentary, doesn't manage their stress, doesn't sleep well, their microbiome is not optimal heading into perimenopause. And so I do think that will lead to a worsening of symptoms versus someone that is probably eating a nutrient-dense whole food diet. And that doesn't necessarily have to be any one particular paradigm, but focused on protein and the right amount of carbohydrates, et cetera. Someone who's been exercising, someone who's been managing their stress and sleeps, they're absolutely going to experience that transitional time very differently. And what I find interesting is things as benign as antibiotic therapy, alcohol, other types of things that we're exposed to. I think a lot about stress. I think that the pandemic is 6 years behind us, but I still think the ramifications from the pandemic, the chronic stress, really impacts the microbiome dynamically. And so I do think that there is a before the pandemic and an after the pandemic effect of health on the microbiome. And so for everyone listening, I think most people have had a course of antibiotics, hopefully appropriately dosed and prescribed. But, every time that you're prescribed an antibiotic, it's killing off beneficial bacteria as well as non-beneficial bacteria. And so helping people understand there are probably cumulative effects over the course of our lifetime that impact the health of the microbiome heading into this middle-age time frame. And there's a lot that goes into symptoms that women experience. I think the most common things that I hear from women is, I don't understand, I'm eating the same food I used to always eat and now I'm bloated. Or I have alterations in bowel patterns. I've had it checked out. Let me be really clear. Phil and I would say, if you suddenly have problems with constipation or diarrhea that are not getting better, that needs to be evaluated. But if you've had it evaluated and there's nothing serious going on, people are told they have IBS. And more often than not, it's underlying food sensitivities that are driving symptoms. But for a lot of people, their symptoms are kind of in a constellation, a bucket of bloating, digestive changes, brain fog, hot flashes, vasomotor symptoms, the dreaded weight loss resistance that a lot of women experience. It's incredibly frustrating. And what do most providers say to their patients? You're just getting older. Weight gain is a normal function of aging. I heard it. I didn't like to hear it. I wasn't happy about it. But I think for a lot of patients, these are just kind of the tip of the iceberg as they're heading into that transitional time.
Yeah, it's just so interesting as I think about the parallels to heart disease, right? And we know how significantly heart disease increases in women post-menopause, right? And everyone wants to kind of blame menopause, but a lot of it is they've had insulin resistance building, they've had other things going on. You lose some protective effects from things like estrogen when you go through menopause, and that contributes, but oftentimes we're dealing with problems that have been longer standing and just sort of become more apparent as women go through this. Ultimately, I know your messaging, right, your books, they're focused on women, but you mentioned a little earlier that this is something that probably men need to think about as well. And although we don't go through such a dramatic hormonal change, there are some similarities there.
Absolutely. And what's interesting is the microbiome gets imprinted, whether we're a vaginal delivery, whether we're a C-section, whether our mothers breastfed us or we were formula fed. So there's something called the microgenderome, which was a term I'd never heard of before until I started writing the book. And it talks about how there's kind of key times in a woman's life and frankly a man's when their microbiome shifts in response to hormones. So puberty, not surprisingly, dynamic shifts. For men and women, if they go through a pregnancy, they're going to get dynamic shifts in the microbiome vis-a-vis alterations in these key hormones, and then perimenopause. And the irony is when women go into menopause and we have all these dynamic shifts, what's interesting is our microbiome starts to resemble that of a man, but it's not necessarily to our benefit because we're unique and different, as we don't have to go into that explanation. But I think for a lot of individuals, they're surprised to know that there's these kind of key times where our microbiomes get imprinted. And to your point that you mentioned earlier, I think for listeners, it's really important to understand there are people that are at greater risk for heart disease heading into middle age. And I'm speaking to women that have a history of polycystic ovarian syndrome, women that have had gestational diabetes, women that have experienced preeclampsia or eclampsia or other types of preterm labors or complications. They are at greater risk for heart disease heading into menopause. And I don't think that is discussed enough. And frankly, I'm not sure. I'm not sure I ever learned that until a few years ago, where I was like, oh, that makes so much sense. Why weren't we thinking about that a little bit more proactively? So it's not just the overt diabetes or insulin resistance. It is really this constellation of, I always say, like, pregnancy in and of itself is a litmus test for metabolic health. And for a lot of women, they fail that first stress test, if you will, in pregnancy. Not a real stress test for listeners, but like the proverbial stress test of pregnancy. But I think for a lot of women, if they knew that, it might allow them to make different changes when they're in their 30s and 40s, especially knowing if 1 in 3 women are going to die of heart disease. We really want to be proactive about this. We don't want to wait until we're in menopause to say, hey, time out. We need to deal with this insulin resistance, this latent diabetes that we have not been managing properly. We need to deal with this proactively and certainly earlier, because to your point about changes in the endothelium, changes in the blood vessel linings that occur in the absence of estrogen, the changes in nitric oxide signaling, there's a lot that goes on. I think a lot of people probably are never told, oh, by the way, by the time they get to you, Phil, they might be on the other side of things. But I think for a lot of patients, they're just not actually counseled, or this information isn't shared proactively to help them make better decisions before they ever get to menopause.
Yeah, I agree. Gestational diabetes is such a missed opportunity because we know what the long-term risks of that are, right? And most women, I think, are falsely given the impression it fixes itself after you are no longer pregnant. But the reality is that no, it's an indicator of underlying problems, and addressing those things in your 20s and 30s when you're childbearing would be so much more effective than waiting till you're in your 50s, 60s, and 70s. And now you're seeing me or one of my associates, and we could have prevented it if we just paid attention to the right things.
Yeah, it's interesting. I remember probably 20 years ago, I was friends with a visiting postdoc from Australia, and he was an ICU doctor, but was doing research. And I remember him saying to me, I don't know what it is about you Americans. You guys do a really lousy job managing diabetes. I'll also add in asthma, but diabetes, you guys wait till your patients get diabetes. And that left me with such an indelible impression. I was like, here we are having this incredibly accomplished, smart MD, PhD who's here doing a postdoc research when I was in Baltimore. And I just recall it left me with such a big impression of, why are we waiting for our patients to develop diabetes? Like, we really should be explaining to them what the ramifications are of having a fasting glucose between 90 and 99. And for listeners, that's not where you want to be. That's not ideally where you want to be. It's about 30% greater likelihood you'll go on to develop diabetes. So if your practitioner is telling you that your fasting blood sugar of 102 is okay, or 98 consistently, there's probably some work that needs to be done. And it really left me with this idea of, first of all, I thought he was correct. And then second of all, what can we do differently? And so here we are 20 plus years later, having this conversation. I still feel like I have to beat that drum, because we as a medical community, not you and I, we are still letting patients develop latent diabetes. We know it's happening, and people are still fighting back about checking fasting insulins. I had a group program, and there was a woman in there saying, My doctor said there's no utility to doing a fasting insulin. And I said, seriously? I was like, tell him or her that this biomarker will dysregulate 5 to 10 years sooner than your glucose. So this is why it's important, and it's dirt cheap, and it's not an integrative medicine test. It's not something that's going to be super expensive. They can write a code to cover it. There's no excuse for not knowing what your fasting insulin is. And sure enough, hers was 20.
Yeah, I never, unfortunately, I see it all the time as well. And just simple things, right? We're really not talking about major expensive tests and things like that. And it's just, there's just such resistance within the traditional medical system to just change, right? It just simply comes down to that's not the way we were taught, and that's not the way that the system has run for all these years. We just don't want to change. And obviously you and I and many of our colleagues in this metabolic health world have thankfully seen past that. And I do think that the environment is starting to shift, right? We're starting to see some cracks and some different conversations happening, but it's still a long way to go.
No, absolutely. Absolutely. I agree with you wholeheartedly. And I think the encouraging thing is maybe 10 years ago I sounded crazy and now I sound a little less crazy. So that's encouraging. Maybe the needle's
Yeah.
moving in the right direction.
Definitely. So one of the recent changes I'd love to get your perspective on, and I know you addressed this some in the book, is hormone replacement therapy. Of course, you think, okay, menopause, decrease in all these hormones, let's replace them. And I know this has been very controversial throughout the years, really was discouraged and shunned for many years. Things started to shift. And now more recently, we've had really a policy shift around this. The FDA recently announced they're going to be or have removed all of the warnings that were on it. And we really now understand that this can be a very useful tool. So talk a little bit about your perspective on that. And I'd also love to hear how that interacts with the microbiome.
Yeah, so you're really speaking to the Women's Health Initiative that came out around 2002. And I was a baby nurse practitioner and safely tucked away in cardiology and told to stay in my lane. But I had plenty of patients that talked about how being taken off their hormones, they had this recurrence of symptoms and how they were just told to accept it and put on an antidepressant or Neurontin or any other alternative to replacing hormones. Thankfully, I would say probably over the last 8 to 10 years, we've seen a kind of 180. Even the North American Menopause Society had a position statement change. The black box warning on estrogen came off in 2025, which is really encouraging. And so I think when we're speaking to replacing what our body is no longer making, we're really speaking to primary prevention for osteoporosis. And we know estradiol has a primary preventive role in reducing the likelihood that women will develop that bone disorder where we have poor bone strength. We know that estradiol can also be helpful for reducing cardiovascular disease risk. And certainly we want to start it earlier rather than later. A lot of the reason why is that it's not to suggest that if a woman's 5 years into menopause, she can't consider hormone replacement therapy. It's just the longer we go without estrogen, the more likelihood we are to develop some degree of plaque in the arteries. Because in that absence of estrogen and certainly nitric oxide, we get a lot of endothelial changes. Progesterone appears to be an easier player. It's not as much concern for that. But what's interesting is there's a lot of research being done right now around brain health with Dr. Lisa Mosconi at Cornell, really looking to see what are the long-term effects of hormone replacement therapy on cognition, reduction in Alzheimer's risk. I think her goal is to reduce the Alzheimer's risk in women by 50%, which is incredible. And then the other piece is there's evolving research about the gut microbiome and how if we look at so before we even get to perimenopause, we get to a premenopausal woman, perimenopause, menopause. Women in menopause that are started on hormone replacement therapy, their microbiomes can then resemble a younger woman's. Now, I'm not talking about the physicality changes that we can see outside our bodies. We're talking about how estrogen at a very basic level is intricately interwoven with the immune system. So as estrogen is declining, we're getting alterations in our immune system. We tend to be more inflamed. We're more like 4 to 5 times more likely to develop autoimmune conditions. There's now over 100. I'm sure when you and I trained, there were probably like 30. Now there's long haul COVID and chronic Lyme are the two newest ones on the block. But, estrogen is also really important for protecting the lining of the small intestine. And if people like analogies, I always say it's like brick and mortar. The estrogen is the mortar that keeps the bricks together. So as estrogen is declining, we're more likely to see leaky gut, and leaky gut leads to these alterations that will ultimately become autoimmune conditions. So the research is certainly suggesting that estrogen has a beneficial role as well as progesterone replacement. Just even thinking, Phil, on a very basic level, women will tell me I'm bloated. I feel like it takes a longer amount of time for my food to digest. I oftentimes will hear, does that mean I have gastroparesis? I'm like, time out before we even worry about that. Let's just think physiologically what's changing. And so the motility in the gut changes in response to alterations in progesterone and estrogen. So progesterone is a smooth muscle relaxant. So that alters motility. And then estrogen, as I've mentioned earlier, is this potent nitric oxide precipitant. So with less nitric oxide signaling, less estrogen, less progesterone, you will get alterations. I recall probably 10 years ago, I remember saying to my OBGYN at that point, I was like, I just feel like when I eat, my food sits in my stomach longer. It takes longer to digest. And she said, oh, you're fine. There's nothing to worry about. But now we look at the research and we're like, okay, this actually makes sense. So there's a lot that goes on. I think that we'll eventually get to a point where we will get a primary indication for estrogen therapy in particular. What's interesting is progesterone, it's very much this Goldilocks effect, like any hormone. But I have patients that we've started them on progesterone and it worsens their reflux, or it worsens some of their other kind of smooth muscle contractility issues. So it's finding the right dose of the hormone replacement therapy for the patient. Testosterone is also integral. It's also important for the immune system, but not every woman needs testosterone therapy. About 25% of women in menopause make enough testosterone. Although that's not the norm, a lot of women benefit from testosterone replacement as well. So the other thing that I think is really interesting is the research is now evolving, talking about the rise of GLP-1s plus HRT, seeing tremendous benefits, obviously, not just in insulin sensitivity and metabolic health, but also changes in body composition in patients that are taking both together. And I would make the argument it doesn't necessarily have to be at high therapeutic doses. These kind of personalized microdoses, we're seeing great improvement in autoimmune profiles, reduction in inflammation, and those changes in body composition. Because what happens for women and men too, but again, not as dramatically, women start to lose lean muscle mass and they start to have more visceral fat, which is the bad fat around our vital organs. But that subcutaneous pesky fat becomes less of an issue. And we just have these alterations in body composition that become really problematic. Women will say, I've lost my waist. And we're like, the visceral fat is what we really want to avoid. So I think judicious use of GLP-1s, at least from my perspective, is certainly a really important intervention for women at this stage of life.
I know Jack wants to jump in. I think this is the longest he's gone without talking on the program.
I don't even know where to start. I've got a million questions. One of the things in full disclosure here, my first wife, I went through menopause with her. And then my next long-term relationship was a girlfriend, and I got to do it all over again with her. And in both instances, from the exterior, from the guy living closest with them, but not actually inside their skin, they were crazy.
Yep.
And as I've been deeply involved in the layman's role as in the metabolic health world, I've found out that my experience as the man in their life was pretty normal. And the story I have for myself right now is that these hormonal changes are largely unavoidable, and that the women themselves feel like they're crazy, like they're losing their minds. And I have told more than one woman, there's no amount of money you could pay me to go through what I've seen you go through. It looks to me like 7 different kinds of hell. With that as background, the question is, can those emotional and psychological effects be at least mitigated, if not completely avoided, just by taking better care of the microbiome.
So I appreciate you sharing that. And I can tell you that 70% of relationships kind of are initiated by women. And I think a lot of it is initiated because they're not able to process what is happening. I think of perimenopause as a litmus test for how well you have taken care of yourself. And by that, when you look at the research on adverse childhood events, I think this is relevant.
Yeah.
Adverse childhood events, and you look at the sequelae of that, whether it's you were exposed to addiction, abuse, neglect, etc. If you have a high ACE score, you're already heading into your teens, 20s, and 30s at a disadvantage.
Interpret that for our listeners.
Yeah. So adverse childhood events, it was a joint venture between the CDC and Kaiser Permanente. Anyone that's listening can go online. You can get access to a very quick quiz. When we talk about trauma, we're talking about something that has enacted a wound. Now, when I trained in inner city Baltimore, you can imagine I saw a lot of big T trauma, murder, rape, suicide, incest, etc.
Yeah.
What has come out of this awareness around trauma is that trauma is more than that. There's little T trauma, neglect, abuse, addiction, things you're exposed to as a child that will imprint your nervous system so substantially that it is going to change the trajectory of your life because your sympathetic nervous system is going to be acutely sensitive and much more aware of your surroundings, things you're exposed to, communication patterns, etc. And so it imprints you differently. We know that people that have high ACE scores are more likely to develop autoimmune conditions. They're more likely to have disordered relationships with food. They're more likely to have poor metabolic health. And this is significant. So this is this imprinting. So I think a lot of people, they navigate their teens, 20s, and 30s with optimal hormones. They get to their 40s and the wheels fall off the bus. And I know that's not a clinical term, but that is how I explain it to patients, that you may very well have had adaptive patterns that have allowed you to exist with that history, that when you have declining hormones and changes and alterations in neurotransmitters, your adaptive patterns become maladaptive. Women have to literally, in many instances, if they do the work, they have to change a lot of what they were doing before from where they were. Now, I think that sometimes people don't have the language to explain what they're experiencing, or they've had underlying trauma that now has really made it imperative that they're doing therapy, and not just little bits of therapy, doing somatic therapy. Now we have evolving research around MDMA assisted therapy, which I'm not an expert in that, but I've done a lot of research around it. And so I think in the absence of these hormones and these neurotransmitters, people can't cope as well. We aren't as stress resilient in middle age. We just aren't. We are hormonally and biochemically just not as stress resilient. So cortisol is an important hormone. It gets a bad rap, but cortisol can be caustic over time. If your cortisol is chronically elevated, you're going to have high glucose, you're going to have high insulin, you're going to deal with metabolic health issues, you're going to deal with an inability to maintain and build muscle, you're going to have a lowered immune system, you are more likely to develop leaky gut. And women in perimenopause and menopause are 4 to 5 times more likely to develop autoimmune conditions. So I think that your experience is what many men experience. I was just speaking on a stage last night, and there were many women there that were saying, I feel like I lost my mind. I felt so much better when I got put on hormones. And sometimes women get put on antidepressants, anti-anxiety agents, and that may help. And there's no shame in that. But what they probably need is optimized hormones so that they're making healthy neurotransmitters. Because when you don't have enough progesterone, which is really the harkening of perimenopause, you don't make enough GABA, which is your main inhibitory neurotransmitter. If you don't have enough estrogen, and estrogen can fluctuate 20 to 30% more in perimenopause, you aren't going to make enough serotonin. It's more complicated than that, but I kind of identify it to say you will do a 360 as a woman in perimenopause. And I think a lot of women that are able to navigate it in their shared relationship with their spouse or their partner, it's probably because they are having an intervention or 2 or 3 that are helping them with their hormones. So I'm so grateful that we're coming back to being pro hormone, because I think a lot of relationships have ended. A lot of marriages have ended because people don't have the language to explain how they feel. I forget the term, it's not coming to me. I normally don't forget words, but it's an unusual word that talks about the annoyance of people chewing. Like I'm one of those people. I've been that way my whole life. It is not a middle-aged woman thing. But there was a woman in the airport who was chewing her gum so loud. I was like, oh my God. But there was someone in the audience last night that said, I thought I was going to kill my husband one night because he was chewing so loudly. And I was like, that is an estrogen thing. That is an irritability thing, is definitely that declining estrogen. So I think there's a lot to your experience, Jack, that is shared by a lot of men and a lot of partners that I wish wasn't the case, because I'm sure when people come out on the other side and they're like, okay, perimenopause is the storm, menopause is much more calm for most women. They're like, if your marriage can weather perimenopause, you can handle anything. But I think that a lot of partners aren't told what to expect, so they don't know how to be helpful. And if the woman doesn't know how to explain what she's experiencing, other than I'm just really irritable and I'm mad, I feel like I have PMS on steroids. That's what I've had some patients describe to me.
Well, that
Like,
was my experience on the outside.
yes, yes. And so I think when men and women are not having these conversations, then it's not surprising that some people are like, peace out, I'm done. Like, I can't handle the
Yeah.
chaos of this middle-aged timeline. And so I think that these conversations are so valuable. And what's interesting is, as I've been talking about the book,
I'm sorry, I got to just pause and speak to our audience right here. Folks, I really thought we were going to have a conversation about biology today. And we are, in fact, having a conversation about biology. But what is far more profound is we're having a conversation about relationships. If you're a man or a woman in middle age and you feel like you're in a storm that you had absolutely no idea was coming along, pay really close attention to the first 30 minutes of this conversation. And I'm going to get the book. I have friends who need to know this. Thank God I am on the other side of it with my wife. And I can confirm for those of you who haven't gone through it yet, menopause as the husband is so much better. I'm sorry, but I'm walking with a friend right now through this storm. It's hell. I've been through it myself. It's hell. And that's as the guy on the outside. I can't imagine what it's like to be a woman going
yeah,
through this.
I think for me, transparently, I was 44 when I left clinical medicine. And it was like I could not have made a different decision. I was just couldn't do it one more day. But I actually said, I think that was my midlife. I remember my husband asked me, are you having a midlife crisis? I was like, no. But I think I was. I think I had to do something that dramatic to change the situation I was in within my job. But I think for a lot of people, there's something comparable that they have experienced, whether they moved, whether they changed partners, whether they got a divorce. I just think for some, it's like they have to move, they have to do something differently. And so I think for a lot of people, they don't have these conversations for a variety of reasons. Someone actually, I was at an event last night and they were showing a documentary, and and in the documentary, they were talking about men having the same type of conversation we're having now. And the men were all laughing. It was a bunch of guys sitting around there. Can you imagine our fathers hearing us having this conversation? We're talking about our wives, how our sex lives have changed and how they're moody and all this other stuff. And they're all talking about how, like, when they got to on the other side, things were so much better. But they said, you don't know if they're going to get better. There's no certainty. It's like we're just kind of going day to day and praying.
Yeah, hanging on by your fingernails. Okay, I
Um,
apologize, but I was looking forward to this conversation just because I know from a biological standpoint, from a health standpoint, it's so important. I had no idea that we were going to be talking about how this affects relationships, our
mm,
most intimate relationships. So please, let's dig in now. What I want to summarize what I've heard and then take it from there. Trauma, big T and little t trauma, affects how your body goes through menopause. If you have a high ACE score, and we'll make sure that's linked, Phil, I'll make sure that's linked on the show notes. If you've got a high ACE score, summarize what you said again for me. If you've got a high ACE score, then
it puts you at risk for poor metabolic health. It impacts your relationship with food. It puts you at risk for autoimmune conditions. And the one thing I didn't mention that I think is significant, that gut ovarian axis, our ovaries are the most mitochondrial dense organ in our bodies. Guess what? Chronic stress ages the ovaries. That's huge. And I think I want to expound upon this because how many patients or personal friends that I know that have had a lot of trauma in their lives that went into menopause before the average, which is 51 in the United States, going into menopause 43, 45, 47, 48. That's significant.
And is that, I was going to actually ask you about that. What you triggered when you commented about the men thinking about their fathers thinking about this, but has there been a change in menopause when we look 40, 50, 60 years ago? Obviously, we didn't have these tools available to talk about hormone replacement and stuff, but it didn't seem to be such an epidemic, right? You went through menopause, it was part of life, and there didn't seem to be as much problems around it as we're seeing today. And talk a little bit about maybe how menopause has changed as our society has changed.
Well, I think there's a couple things. Up until 2002, there were quite a few prescriptions written for HRT. So HRT was common until the Women's Health Initiative. I think there are societal expectations. Like I know my mother's generation, my mother just turned 80. So she's from the baby boomers generation, World War II. Those women did not talk about their age. My mother told me she was 30 years old until I was 30. I'm not exaggerating. Until I was really, my mother never had a conversation with me about menopause. Never. I don't know when she went into menopause. That generation is very age conscious and they were told to shut up and they weren't told to express themselves. They might have been the generation that wanted equal pay and fought hard to be accepted in the workplace. But that generation is they're not as apt to talk about things that are private. And so my grandmother, who passed away over 10 years ago, had a hysterectomy at 45. And she said to me, she was a retired nurse, she said, Cynthia, I was never offered hormones and I was told to just ride it out. So we can talk about the patriarchy in the medical system and how women have suffered in many instances. And I think that whether it's painful periods, whether it's postpartum depression, whether it's contraceptive options, whether it's perimenopause and menopause, I think there has been this expectation that women suffer in silence. And I think my generation is unwilling to do that. We're a bit more spitey. I don't even want to say spunky, but I think we're apt to talk about things. And I think the social media has allowed people to share their stories in a way that's different. And so I think that it's both a time and a place, different generation. Now we have social media where people overshare. People share a lot. And then there's like the oversharing where people share way too much. But I think people are sharing their experiences. And so that resonates. Women are realizing like, I'm not the only one experiencing this. But my mother's generation, a lot of ageism and shame around aging. And I think the other thing that I would add to that is some women really get caught up in no longer being fertile because that affirms that they are not young anymore. Most people that are average age of menopause is 51. I think for many women, they're very sensitive about their age. Like I know my mother's sisters are. And there's like this shame and secrecy around aging and fertility. And so I'm not blaming anyone, but I do think that the traditional medical system, and this is reinforced by the WHI and the past 20 years, women were just expected to figure it out. You can't sleep? Too bad. You have terrible hot flashes, in which we know are a prognostic indicator for later cardiovascular disease development. You start to think about this domino effect of women being told to shut up and just deal with it. And I think that we're just in a time and a space now where women are unwilling to not demand better care. I hadn't planned on saying all that. You can cut that out. But I think that if we're looking at past generations, I do think that plays a large role. Women were not encouraged to speak up, whereas now I think women will speak up. And I hope, and my intent is that by bringing greater awareness around the aging process in general, there'll be less shame. Like I have women that don't want to talk about their menstrual cycles. I'm like, all right, this is a normal physiologic thing that happens. We should be able to talk about I have an 18-year-old and a 20-year-old. They know about what menopause is and they know what HRT is. And I'm like, this is great. We've got younger generations that are not, there's no stigma about it. They're happy to talk about it. In fact, my 20-year-old called me one night and said, mom probably needs to come see you because they're really emotional.
This feels, oh my God.
Poor Phil
Oh,
and Jack.
no, well, no, I'm so stoked about this. I'm so excited about this. And in full disclosure, it's entirely possible my memory is not perfect, but in my memory, the last, I don't know, 20, 30, 50 guests we've had, we've been dealing with some very specific kind of issues, symptoms that can have very specific solutions, or very broad-based symptoms that can have very broad-based solutions. Hey, you're fat because you eat bad. You don't exercise, you don't get out in the sun, and your sleep is terrible. Fix that, and a lot of these problems go away. But what I'm hearing here are some things that affect a huge number of people, affect all women.
You live long enough, it's
If
absolutely
you
like
live long enough, every single female listening to this is going to experience this, and every one of the important emotional connections in your life that go through it with you are going to be affected by it. And yeah, there's tremendous physical benefits from getting this straight, but it's not merely physical. It's relational, it's emotional, it's psychological, it's mental. It can affect your career. It can affect every choice you make in life. Dear God, I wish I'd have known this 25 years ago.
Yeah. I think it's vital information. Like I
No,
truly,
beyond vital. This
yeah,
is whatever the next level up above vital. Uh,
yeah. No, I think that when I was writing this book, it coincided with probably the hardest 18 months of my adult life. I lost my dad, I lost my stepmother, I lost my stepfather, my husband got sick, he was hospitalized twice in the midst of writing this book. And I remember saying, this book is so important. It's so important because no one is talking about the gut. I think that there's greater awareness around perimenopause and menopause, which is fantastic.
yeah,
It's so necessary, but no one's talking about the gut. And I think it is the missing link to all these other things. It explains why you can just start a woman on HRT and it doesn't fix everything. Because if you haven't fundamentally dealt with the gut microbiome, and how many women listening, I did a post on Substack in February that went viral because I talked about my own experiences having quite a high ACE score and how it impacts your nervous system. And do I think that probably gave me a slightly worse experience in perimenopause? Probably. But then I got myself back on track and I'm great now. And my marriage is stronger for it. But I think for a lot of individuals, they just never have these conversations. And men have to be part of the conversation.
yeah,
Because if we aren't talking about it, two men, like openly, honestly, and doing so in a way where they don't feel like they're being preached to. It's just, this is my experience. Jack, you shared your experiences, and poor Phil is, I'm sure, Phil, you have an experience, you have some experience along the trajectory as well. But I think these conversations are so necessary without shame, without stigma, without feeling like we neatly keep gender in a box. This is for the men and this is for the women. It's no. If we want to have healthy relationships, we have to have these conversations.
Yeah, and definitely. And again, as much as I talk about heart disease and how that touches almost everyone, right? Menopause, like we said, it literally is going to touch everyone, either directly or kind of as a first degree there. You have a partner, you have a mother, you have daughters, or whatever it is, they're going to go through this as well. So everyone really is touched by this. And you're right, it's not something that got talked about enough and talked about openly. And there are so many areas of medicine where we under recognize, right, how gender plays a role in it and gender differences and all these various diseases. And it is good to see this getting the attention, and it's good that we're getting tools to help women deal with it. And now we have to destigmatize that. And so it can be more widespread. And like you said, it isn't as simple as, well, just treat the hormones. This is systemic, it's got the psychological components to it, and it's got gut that no one thinks about, and all these other things, that it's not just as simple as prescribe the hormone and get it dialed into the right range and everyone's going to be fine.
Yeah, and I think what's interesting is I would make the argument that if someone's gut is not healthy, it will magnify all the symptoms women experience. There's a special part of the microbiome called the estrobolome. I did not name it.
I've
That
never
is
heard
what
that
is,
word before.
yes. Someone on another podcast called it estrobolome. And so every time I go to say it, I have to catch myself because it makes me chuckle. That's how they pronounced it, which is probably how anyone would pronounce it if they didn't know. But this estrogen processing center of the body. And so I remind women when you're in perimenopause and your estrogen can be 20 to 30% higher, which can drive a lot of the symptoms women experience. If you are not breaking down your estrogen, packaging it up, and pooping it out of your body, you are going to get this recirculation. It's this enterohepatic recirculation of estrogen, which can magnify and worsen all those symptoms. So the brain fog, the night sweats, the skin manifestations, the digestive issues, all of these can be worse. Weight loss resistance, which is the biggest pain point of all, it worsens all these symptoms. And so you layer that into, I don't mentally feel like myself. And it just magnifies everything that women experience. So you can also, I would argue that if you're heading into perimenopause with a healthy gut microbiome or a healthier microbiome, you probably will fare better than someone who does not. And I think for the average person, what is it? 92 to 93% of Americans are not metabolically healthy right now. Of the percentage, there's 6,000 women a day that go into menopause. Gives you a sense, and the scope of the problem is enormous. It really is.
Yeah, it is.
Let's maybe touch on that a little bit, right? Because one of the challenges that comes up when you start talking about the microbiome becomes, okay, we acknowledge that there is a relationship between the bacteria and everything else that are living in your gut and everything that's going on in the rest of your body. But how do we measure it? How do we test it? How do we affect it? And I know as part of the book, you lay out a great plan, but let's talk a little bit about, okay, so a woman's going through menopause, they're having a tough time, they're hearing this, they're like, great, I got to figure out my microbiome. Where do you start?
That's such a great, that is a clinician-led question. So we always start with the basics because we know sleep impacts the microbiome dynamically, stress management impacts the microbiome, nutrition. Those are like starting points, protein and fiber. And I know sometimes fiber can be the new F word. I have to be careful who I say that to. Exercise, all really important. So those are majoring in the majors, as I call them. When we're talking about dynamic testing, it's looking at hormones, it's looking at metabolic health, it's looking at stool testing, which I know in a kind of a conventional sense, the traditional allopathic people would say, I check poop for two things. I make sure you don't have traveler's diarrhea with ova and parasites, and I make sure you don't have any blood in your stool. This is more than that. We're looking at a certain stool testing can look at keystone bacteria, which are really important. They can look at inflammatory markers. They can look at dysbiosis, which is essentially non-beneficial inflammatory bacteria that we will start seeing more of in the absence of those hormones. We can look at your digestive fire, which is not a clinical term, but for listeners, I will explain it. We can look to see, are you producing enough stomach acid? Because if you're not producing enough stomach acid, you're going to have trouble breaking down protein into amino acids, which is what your body can use. If you're not making enough digestive enzymes, which we know decline also with age, you may not break down protein, fat, and carbohydrates. What's also interesting, Phil, is that bile changes in the absence of estrogen. Estrogen and bile go together. So how you break down and emulsify fats can also be impacted in terms from a digestive capacity. So when I'm looking at stool testing, I'm looking at keystone bacteria, I'm looking at inflammatory markers, I'm looking to see, do you have fecal fat? Meaning, do you not break down your fat in your stool? And it's evident, it shouldn't be there, but it's evident. Do we know if you're detoxing properly? So there's an enzyme called beta-glucuronidase. If that's elevated, that may be a sign that your body's not properly breaking down your estrogen and you're recirculating it. So there's definitely inflammatory markers. We can look at SIG-A, which is a marker of immune function. We look at calprotectin to look at a marker of inflammation. If that's high, I'm starting to think about more concerning things. They may get a referral to GI to get further evaluation. But just from a starting point, like those are basic things that I will do. Looking at a fatty acid analysis, we still are dealing with the after effects of being fat phobic for a very long period of time. I know when I started in clinical practice, I used to tell people to use bromelain brown and like Smart Balance and don't eat the butter. And I always say no better, do better. But being very saturated fat phobic for a long period of time, we still have some deficiencies that will show up. That's a starting point. A lot of times patients want to know, oh, I want to know these saliva tests. Yes, if we want to look at cortisol, that's a great way to get a sense of what your cortisol is doing throughout the day, as opposed to a blood test that just gives you a one-time reading. Looking at other types of hormones, we can look at a pretty comprehensive hormone panel. Depends on where you are in your cycle, if you're still menstruating. If you're in menopause, we can test it at any time. But those are starting points. And I think that food sensitivity testing tends to be a little controversial. When I was writing the book, I had to kind of identify if you have food allergies, we have solid science on that. Food sensitivity, although I've found it to be beneficial when patients, we've done a Whole30, we've done like the major inflammatory foods, but they want to dig deeper. They're not satisfied. They're still having symptoms. Sometimes those food sensitivity tests can be valuable. And so that may be another piece of the puzzle to kind of get a better sense of what's going on. But that's a starting point. Obviously, as you and I know, the most important thing that we do is get a really good history, because that usually gives us a gestalt of what's going on with the patient, what direction to go in. But I find those to be valuable. The other thing that I'll just add is, as much as I love integrative functional medicine, I think sometimes we get too caught up in the weeds of tests. We have all these tests, tons of supplements. Middle-aged women don't need more things to be super complicated, which is why I always say major in the majors. Get your sleep dialed in. Don't buy the Oura Ring until you've got your sleep dialed in. Manage your stress, because if you can't manage your stress, you're not going to sleep. Change your diet. Those are big things for patients to do. So I try very hard not to make it overcomplicated, because I laugh. When I was a new nurse practitioner, I would send my patients home with these really detailed instructions. I'm like, they couldn't change 20 things. Now I'm like 2 or 3. Go to bed 30 minutes earlier and try to eat more fiber in your diet. It could be that simple, just to kind of give them some direction so they don't feel like they're swimming in overwhelm. Because when you're dealing with depleted hormones and changes in your neurotransmitters, you're not going to cope quite as well. So you may not have the ability to manage. Or a lot of women get diagnosed with ADHD in middle age, and it's like they've been dealing with it pretty well their entire life, but with those changes in hormone levels, all of a sudden they're like, oh my God, I can't cope, and I can't think, and I can't like logically executive function, because I just am dealing with a alteration in my physiology.
Yeah.
And what are maybe some of the things symptomatically that women can be looking for to help them figure out, am I going through menopause, sort of regular menopause, or am I going through menopause with gut problems that are making it even worse?
Such an important question. So number one, let's define, like, average age of menopause in the United States is 51. If you go into menopause before 40, that's considered to be premature. And those patients actually have to be treated much more aggressively with hormones to get them back to where they would have been if they had not gone through menopause so early, or finding the reversible cause. Early menopause is before 45. So just to find those differentiators, I think for a lot of women, the first signs of perimenopause are an uptick in mood disorders. So more anxiety, more depression, certainly sleep issues, especially the week or two before their menstrual cycle. So that's usually the first big symptom. When I start thinking about gut-related symptoms, it's almost always bloating, changes in their bowel habits. And like I said earlier, if someone acutely has a change and it needs to be evaluated, get that evaluated first, and then we can kind of work backwards. But someone who hasn't been particularly constipated, who suddenly can't go. Someone who's never had issues with diarrhea, who suddenly has diarrhea all the time, or new food sensitivities, or someone that's experienced weight loss resistance. Almost always, it's a multifactorial. There's multiple things that are contributing to it. But I would almost always say, because there's this strong gut-brain connection and the communication with the vagus nerve between the gut and the brain, almost always, if you have gut health issues, you almost always have mental health concerns or issues that really can unwind. And if someone's had significant PMS their whole life, or even has PMDD, there are some women that are just much more sensitive to alterations in hormones. And I think they typically, because they are so sensitive to hormones, those fluctuations day to day, week to week, can really magnify all of their other symptoms. So that's a good starting point. But perimenopause is as unique as we are. Like I say, I could tell you what my symptoms were like, but that was me, like the power of the N of one. And for a lot of patients, their perimenopause symptoms are as unique as they are. I think documented, there's over 100 symptoms, but some of the most common ones are related to brain neurocognitive changes and mood disorders.
I'd go ahead and speak to the partners. If you see the woman in your life around that age, maybe you need to ask her some of those questions about her physiology, what she's experiencing. Maybe she's not going to say it, but if she's acting insane, and I may be a little hyperbolic here, but a woman who's been largely emotionally predictable for your entire relationship and suddenly turns into something completely unexpected, that might be worth looking into, might be worth asking about. God knows, just understanding what's going on can help us navigate and walk with our partners through these difficult times.
And I think that's, you really have to think of yourselves as a team. You're in it together and you're going to figure it out, and you're committed to working through it and better understanding the behavior and being able to adapt. I remember one of the people that was talking last night was a male, and he was saying, how should I support my wife? And I said, the fact that you're here, the fact that you're asking that question tells me that you're way ahead of the curve, but I would just listen. She's going to have times when she needs to talk about what she's experiencing, and men generally want to fix things, which is great, but sometimes she just needs you to listen.
There you go, folks. Relationship advice right here on the Stay Off My Operating Table podcast. Cynthia, real quick. I'm sorry. Go ahead, Phil.
Yeah, no, I was just going to say, let's tell people about the book, where they can get it, and then also talk a little bit about how you work with people these days and where they can find out about that stuff.
Yeah, thank you so much for having me, Phil and Jack. The Menopause Gut is probably at this point will still be on pre-sale. You can get it at any of your major bookstores. So Amazon, Barnes and Noble, Target, Books A Million, et cetera, et cetera. I really do think it's the missing link for middle-aged women and better understanding their partners, their loved ones. And I would make the argument, if you think perimenopause and menopause is just slapping on an estrogen patch, there's so much more to it. And this is a really nuanced conversation. Really, this is a love letter to women. It's the book I wish I had 10 years ago, which I didn't have. And so I'm active across social media. I have a great podcast that Phil has been a guest on called Everyday Wellness. I would say I'm probably most active on Instagram and slowly evolving on Substack. That's kind of been my new kind of focus for 2026. In terms of still working with patients, I'm working just in group programs at this point because I've now speaking and travel has just become such a large part of my practice. And I do still work one-on-one with patients, but now I've got a much smaller practice than I used to have. But always an opportunity. I have advanced practice nurses who work on my team. So there's opportunities to work with other advanced practice nurses as well as health coaches. I'm really proud of that group of dynamic women. They serve women in a way that I think is unique and very supportive.
All right. I think we've got the information needed to get folks farther down the road. The book is The Menopause Gut. The thing I do once we end this podcast is I'm going to go order a copy.
Thank you.
At least one copy and possibly more for my friends with wives and partners who are experiencing this. All the contact information will be available in the show notes. So thank you, Cynthia, for being on here. You've far exceeded my hopes and expectations.
Thank
Particular
you.
conversation.
Thank you. It's been an honor.
It's Stay Off My Operating Table. This is Dr. Philip Ovadia. Thanks for being with us, folks. And hey, if this was good for you, share it with somebody you love, okay? We'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.